Hey, good morning, everyone. Thank you for joining us for our Compass HIN April office hours. My name is Sean Laffey, the program specialist for the Compass HIN team. And we will be discussing the new readmissions report here. Kate Carpenter from the Compass HIN team will be on to discuss that for us. A few housekeeping items. Please, maybe in the chat, if you can maybe tell us who's present today. Please say who your name or your facility is. Just make sure to also mute your lines and don't place us on calls so we can prevent any on-hold music. And if you have any questions that you'd like to present to us at any time, please utilize the chat box for that as well. And this session is also being recorded, so if you want to review it for later, you can also look to Innovation for that as well. Now we're going to start with a few reminders before we get into the new readmissions report from Kate. Just remember, check out Innovation for some training items. We'll have the health equity training from on May 2nd. I believe that will be next Wednesday. This training is actually designed to help organizations identify and implement practical strategies in response to committing to the AHA 123 for Equity pledge. And we also are having in the next few months the Safe Zone workshop. This will be a day-long workshop. I believe it's going to be at the Iowa Healthcare Association Center downstairs, so at our location. But this day-long workshop is facilitated in a non-accusatory manner, so all participants feel comfortable as they begin to learn or deepen their understanding of the LGBTQ issues. Again, I believe it's going to be at the Iowa Healthcare Association location. And remember always to check out Innovation for upcoming free webinar learning events. You can always check out the open forum or even the events section for upcoming webinars. And you can always reach out to the HIN team as well for any questions or concerns. A couple of items to keep in mind for your calendar. The Opioid Guardianship Take 2 Patient-Centered Care Monitoring and Disposal webinar will be next Thursday. Coming early next month on Tuesday, May 8th, will be the Compass HIN May 2018 Learning Community. We will be offering $125 flex dollars for critical access hospitals that are attending to help cover travel expenses. Make sure to check out Innovation for registration details, and if you're having any issues with that, please reach out to us as soon as you can. Also keep in mind for the CARE Coordination Conference on Tuesday, June 12th. Now, for our upcoming office hours in May, for the month of May, we're looking to reflect on how nurses inspire, innovate, and influence our patients and healthcare communities. Throughout the month of May, we will be celebrating our dedicated professionals that lead our facilities as dedicated caregivers for their patients, healthcare staff, and families. For that office hours, please join us on May 20th, 2018 at 11 in the morning. Now, to prepare for our upcoming office hours in May, if you can please maybe put in the chat some questions or ideas how maybe when does your organization recognize and thank nurses for their hard work and dedication? Does your organization have a successful recognition tradition or program? What methods has your organization utilized to promote joy at work? Would you like to share your recognition traditions or programs in a conversation during May's office hours? We can maybe open up for some more conversation during that to share between our facilities of what best practices are shared. If you would like to maybe put some of these answers in the chat, that'd be very helpful. For promotions for National Nurses Week and recognition for the month of May, please keep an eye out for promotions on our we'll post through social media. Always make sure to keep an eye on Innovation as well. May 6th through 12th will be National Nurses Week, and the 13th through the 19th is National Skilled Nursing Care Week. And with that, I will turn it over to Kate Carpenter to discuss our new the new readmission reports. Kate?
Good morning, everybody. Good morning, Compass HIN. It's good to see some familiar names on the line this morning. We appreciate you joining us while we learn just a little bit more about the new readmission reports we're providing hospitals in the network. Again, my name is Kate Carpenter, and I am the Refuel project lead and also a clinical quality consultant for the HIN. So before we get started this morning, I thought it would be really valuable just before we dive in to give you a little bit of context on how these reports came to be and the reason why they were developed and sort of how our vision, I guess, manifested itself on how hospitals might use these reports as they further their readmission work moving forward. So pausing as we get into that and remembering, really rooting ourselves in our goals and why this work is important. There is 2 goals that HINs across the nation are working on, and that's to reduce all-cause patient harm by 20% and to reduce 30-day readmissions by 12%. So one of our key goals is focused around reducing 30-day readmissions. So as we entered last year, as we wrapped up year 1 of the HIN and started closing down 2017, our team really paused to take a look at how are we coming with our network of hospitals and achieving those 2 goals. And when we look at readmissions specifically, you'll see on this slide, really what we found out is we had lost a little bit of traction. We had been able to kind of maintain our readmissions reductions to date that we'd achieved over previous years, but we really were having trouble achieving that 12% reduction, although we were pretty stable in performance. So as we got stuck, we really started looking and studying some of the national strategies, some of the emerging data, and really paying attention to what our HIN colleagues around the United States were doing, and realizing that it was time to go further than LACE scores and follow-up appointments and rounding, and that we really had an opportunity to design a project with the hospitals who are ready and willing to come with us and test some new strategies. So that's really where the Refuel Readmissions project was born. And if you're not familiar with the project, it's one of the Compass HIN projects we started in January of 2018. It's a 6-month project. We're in phase 3 of the project right now and wrapping up the project in a couple months in June. But one of the things that we gleaned from our Refuel project work was just the opportunity to refresh our understanding of the data, slice and dice it in different ways. It gives us some new insights and allows us to identify different target populations that we might not have appreciated before. So again, as we pushed further through the project, we learned about some new strategies and really focused in on how to intensely use our data to drive our decision making and to really leverage that data to help us design the right interventions for the right patient populations so that we can get the most leverage out of our efforts. And then using that data so that we've got the ability to be proactive versus reactive and meeting patient needs. One of the other things that we focused in on is some new tools. One of those is the Compass HIN Readmission Report, which is what we're going to talk about today. What it looks like, what the facility report looks like versus the facility-specific, network versus facility-specific, excuse me. And then how often should we look at that? How often should we take a fresh look at the data? Also using new approaches, targeting patient populations using that data, leveraging readmission interviews as a strategy to learn more about root cause and why patients are coming back. And then identifying unmet needs and mobilizing our enhanced services as we learn more about what are the real human factors that result in readmissions. And then new ways of thinking, using a front door versus a back door approach, using the emergency room as a readmission reduction strategy, and really catching those patients as they represent into our facility before they're readmitted. For the purposes of today, we are going to focus on this new tool, the Compass HIN Readmission Report. Okay, so a couple quick things, key points about these reports that I want to make you aware of before we open them up. Every report has an associated data dictionary that should be used to correlate the data with the source timeframe and give you some interpretation guidance. So I'll give you an example of this, but every report, there's one report for our Compass HIN, all the hospitals that we have that are submitting data to IPOP, and then there'll be one that you receive that's facility specific. Each of those two reports will have a data dictionary that you can use to correlate some of the information so you know where did this data come from, what time period is it showing me, etc. Each visual in the report represents all the active hospitals enrolled in Compass HIN unless otherwise noted in the dictionary. And all medical coding is in ICD-10 form. And we've got a link on the data dictionary so you can look up some of those codes that you find most prevalent in your readmission report. All the graphics have the data source of either the Compass HIN database or the Iowa Hospital Association IPOP or inpatient outpatient or the real data file, which is that race, ethnicity, age, and language information that we're able to incorporate. Each hospital that submits the IPOP will be able to receive a facility-specific version of this report. Due to hospital sizes, we know here in the state of Iowa, our network of hospitals is primarily critical access. So just as a pure result of volume, there are some data points that are available for our state, our Compass HIN report that we can't pull for individual hospitals just because there's not enough data there to populate each of those data points. So most of our critical access hospitals will be receiving a smaller facility report. And if you have a larger facility, PPS hospital, you'll be receiving a larger facility report. Okay, so here is what it looks like. This is first page on the left-hand side of your screen of the Compass HIN Hospitals Readmission Overview. To the right of your screen, I did include a screen capture of the data dictionary or the first page of the data dictionary. I want to illustrate for you that each page of the readmission report has tables, and if you'll look there in the top middle, you'll see CH1.01, and each of those table codes has a correlating section of the data dictionary found on the right-hand side. So you'll see the first bullet point on the data dictionary has CH1.01. And so that, if you correlate back and forth, please do, when you use these readmission reports, have your data dictionary pulled up and use them side by side so that you're able to identify what period you're looking at and what data it is showing. Okay, so let's dive into these just a little bit as we look at page 1 of the readmissions report. This first field of data on the left-hand panel does show readmissions data from October 2014 through August of 2017. So you're looking at about 2.5 years of readmissions data there in that left-hand box, the solid panel box right here. This is going to indicate for our network our baseline performance right here in the middle on the red line, what the rate was back to any hospital and what rate was back to same hospital. And again, this baseline is established in 2014. Also, it'll show you if we were to achieve as a network that 12% 30-day readmissions reduction, these are the rates we'd want to achieve there on the goal line. And then current performance and the period. You'll see tables CH1.01 through CH1.04 do have a time lapse of readmissions trending information. You can see on a run chart It's trending both counts at the top two tables and rates at the bottom two for about 2.5 years. So from 2014 through 2017, just so you can get a look of how our overall readmissions rates and counts have trended over time. The bottom of this report does represent data of a shorter time frame. Let me get to the same screen as you here. Okay, so starting with table CH1.05, moving over and down throughout the rest of the pages of the report, this data represents index discharges from January of 2017 through July of 2017. So we're looking at approximately 6 months of readmissions data throughout the majority of the report. And the reason that we elected to use this 6 months of data for the majority of the report is at the time that we pulled this for the refuel project, it represented the most current validated 6 months of readmissions data available through IPOP. So we'll work our way through table by table. We'll have to be brief here due to time, and then we'll allow for questions at the end of the session. So starting with CH1.05, right here on the left-hand side, you can see that this is top ICD by readmission counts for the network. So you can see that that code A419 resulted in the highest count, the highest number of readmissions during that 6-month time frame, and it read as a rate of 11.1. But here in the table CH1.05, these are the top ICD readmission counts. Similarly, to the right, CH1.06, this is top ICD readmission rates. So very similar to the table on the left, but this time it is ordered by ICD codes resulting in the highest rate of readmission. So you can read those. If you read them like a sentence, you could read that code D6481 here in the middle, this top code, had the highest rate of readmission during this 6-month time frame. That was 11 readmissions, which was a 55% rate, which, as you'll see, is the highest rate in the table shown. Now I want to just illustrate a couple of things here. These are just the top counts and rates codes. So you're not going to see an all-inclusive list in the Compass Henry report or in your facility-specific report, but you will see the top ICD codes resulting in the most readmission counts and the highest readmission rates. Here to the right in CH1.07 and 1.08, this kind of digs just a little bit further into this data, and you really can start to appreciate what diagnoses codes are resulting in these early bounce backs, where these patients are coming back within that first 5 days post-discharge on the index, and see if that yields any important data elements for your organization. Again, just like on this side where it's ordered first by counts and then by rates, these two tables are the same. So you're going to see right here is the percentage of readmissions within 5 days. Down here at the bottom of the page, we do have some hot spotting maps where we look at by county the Iowa readmission count. When you're looking at these hotspot maps, both on the Compass Henry report and on facility-specific reports, I want to make sure that you're really looking at the scale, which is on the very bottom. And on this case, you can see that the lower end of the scale is 3 readmissions, and the higher end of the scale is 1,162. Notice that as you kind of flip from hotspot map to a different one, the scale is different. So if you're saying, hey, wait, my county is light blue on table CH109, but it's red on CH1.11, we'll make sure that you're noting that the scales are different, so you're not comparing apples to apples. Here in the middle column, you will see CH1.10. This is top county counts. So which counties had the highest count, the highest number of readmissions? Moving forward to page 2 of the full report, some of the other data elements illustrated here are CH2.01 readmission counts, days since discharge. And these are some really great ways to slice and dice your data and start looking at it different ways. You can see here, and I'd encourage you to correlate these with your facility-specific reports when you start receiving those, because what we show when we look at this table is that there's an incredible opportunity to help, lots of leverage, I guess, in focusing in on those first 5 days post-discharge. If we focused in on those first 5 days, how much could we reduce readmissions, knowing that the highest number of those patients are coming back within those 0 to 5 days post-discharge. In the table to your right, CH2.02, this is the length of stay and how it's correlated with the readmission rate. So it's showing, our patients that stay in the hospital 0 to 5 days more likely or less likely to be readmitted. And what we actually see here in the state of Iowa is that longer hospitalization does not mean that your patients are at less risk, that's a tongue twister, for readmission. In fact, that's the opposite is true. We see if the index stay is 6 days or higher, they're actually at a little bit more increased risk for readmission. On the top, the table to your left, CH2.03, this is readmissions by weekday discharge breakout. So we start to look at, is there any opportunities to track trends in if we discharge patients, for example, on the weekends? Are those patients more likely to result in a readmission than the patients that we have discharged during the weekday? And interestingly enough, what we found here in Iowa was that that's really not true. Our Sunday, you can see the readmission rate is 6.2, and on Monday it's 8.8. So there wasn't a lot of really strong information here, but when we looked at facility-specific reports, which again you'll all be receiving, we'll share with you how at the end of this webinar, you may find that in your own organization that there's some interesting findings in this table CH2.03, your weekday breakout. Here in the middle of the report, this is just looking at some trending lines, looking at readmission count by patient age. Of course, we know that this is somewhat true, that as patients age, they're higher risk for readmission. But this table, CH2.05, readmission rate by patient age, breaks it down even more clearly. And what we did discover that was somewhat, I think somewhat interesting, was a lot of our readmission strategies are focused in on these patients who are 60 and older or 65 and older. And actually there was some significant data showing that we might be missing these patients hospitalized in their 40s and 50s in our readmission reduction strategy, because they too are at a higher risk, or return at a higher rate for readmission, I should say. So I would encourage you to look at some of that facility-specific breakout and identify some opportunities. Here at the bottom end of this report, CH2.07, this is the ICD breakout by index and readmission. And what this really shows is when patients are discharged from their index admission, if they do come back, if they do get readmitted, do they get readmitted with the same diagnosis that they originally left with? Are they coming back with something different? And what we found, at least in the statewide report, is nearly 90% were coming back with something different. And you'll have this information again in your facility-specific report, so it'll be great to look at. A couple things, I mean, obviously that's a pretty big statistic. One thing to keep in mind is with the specificity of ICD-10 coding, this is looking at codes very, very specifically. So for instance, if somebody came with their index and they were coded I-110, hypertensive heart disease with heart failure, and then when they were readmitted, the code that was used as primary was I-119, hypertensive heart disease without heart failure, or 1130, hypertensive heart disease with chronic kidney disease. If there's any variation, it's going to show up in a different bucket. So just keep that in mind when you're evaluating that data finding. Okay, so moving along into these tables CH2.08, 09, and 10. Again, these are further breaking down same index and readmission percentage. And then different index, so patients that come in with the same diagnoses, what are those diagnoses codes that if patients are more likely to return with the same thing or more likely to return with something different. Here at the bottom, skipping a little bit too much forward. So CH2.11, here at the bottom, here's where we start to see some of this real data. So looking at race, looking at age, and male versus female. Are there any trends in looking at when we start breaking down different ethnicities? And so once again, I would really encourage you to look at these data points as you evaluate your facility-specific report. Moving along to the next page of the report here, and I know that these on PowerPoint, these numbers are hard to read, so bear with me and just know that this information is coming your way. But what we have here in this top table to the left, CH3.01, is this is primary payer by count and rate. So looking at, is there any information we can track and trend by payer in, when we look at rate of readmission? And I think you'll find there's not a lot of surprises there. Time series count, and also then looking at here on the right-hand side at the top, table CH3.03, Medicare or managed care index ICD count. So looking at in certain payer populations, which ICD codes are the most likely or have the highest rate of readmission coming back. Okay, and in the middle of this report, some more hot spotting by payer. And then the same information that we showed above by count is also broken down, or by rate is also broken down by count in the table and in the math. At the bottom of this page, this is one of my favorite tables of this report, table CH3.08. This is the patient discharge status by count and by rate. And what it does is it breaks up for the network when patients are discharged and the ones that result back in readmission, were they discharged initially to home, to self-care, were they discharged to a skilled, to a rehab, where did they go? And was there any information that we could find out about, was a certain discharge disposition more likely to see the patient coming back? And so we did find out some information, for instance, the discharge status, the rate of return for home was 6.3, whereas some of the rate of return back from a skilled or a swing bed was 13.5, 15.5. So that was an interesting data point. I think oftentimes we think patients are safer when we discharge them to a swing bed or discharge them to home health or to rehab versus a patient that's going home, because we know somebody's helping take care of them. And oftentimes, and national data correlates this point too, that patients that are going somewhere are going home with home health or going home or going to a long-term care are actually more at risk for readmissions. That's why they are being discharged to those locations. So this is a really strong data point for your consideration. CH3.09, the patient discharge status by discharge weekday, so more breaking it out into days of the week over a time lapse as it correlates with the discharge disposition. So those black bars you can see there are home or self-care patients. The blue bars you can see here on days of the week represent skilled nursing facility, and then the yellow represent organized home health service. So you can also break it down that way. At the bottom of this page, CH3.10, this is top home health care index counts, and next to it, top skilled nursing facility index counts. So you can see we've sliced and diced this several different ways, looking at payer, looking at discharge disposition, looking at different ICD-10 coding. And so this is just extremely data-rich information. The last two pages of the reports are summary pages. And so what it does is it takes the top 3 readmission ICD counts. And so I'm going to back up a couple slides so that we can correlate these two things. So what it's doing at the back 2 pages is it's taking the information from tables CH1.05, this top ICD readmission count. It's taking those top 3 from both the Compasson, and it'll do the same thing on your facility-specific report. And then on the very back page, it's taking top ICD readmission rates, so these top 3, and saying, well, folks are probably going to want to know about the top 3 diagnosis codes that result in the highest count of readmissions and the highest rate of readmissions. So let's give them a summary page that breaks that down a little bit further. So that's what those last 2 summary pages are for, and I'll flip back to those and we'll talk about them. So top 3 readmission ICD rates. So you probably can't read these, but this is hypertensive heart and chronic kidney. Again, it resulted in 50, and the rate was 30.5. The second highest rate was 19.9. Very similar code, you'll notice. This is I13.2, and this is I13.0. And then finally, the third highest rate resulting in readmission, type 1 diabetes. So it breaks those down and gives you a little bit more information on each of the 3 of those as far as readmission ICDs. So when the patient came back, what diagnosis code did they come back with? And here at the bottom, days since discharge percentage. So for this code, how many of those patients returned within 0 to 10 days specifically for this code? Well, look, a little over half. Wow. So if we were focusing in on people with this diagnosis code and creating interventions that targeted that 0 to 10 days post-discharge on the index, that would be a really powerful intervention. I know that we are closing in on time, so I know some of you will be having to drop off, so I'm going to fast forward just a little bit through this report, knowing that certainly you can reach out to your improvement advisors for additional information on interpreting and using this report if necessary. But I wanted to highlight some of the opportunities we think you have is just using this report to really create an aim, looking at this report to identify what your data shows, what your biggest opportunities are, so you can select who makes the most sense for you to focus on. And then using that information to really drive your strategy and targeting what will then, if we're going to be focused on COPD patients in days 0 to 10 post-discharge, then what services, what enhanced services could and should we deliver? And just an important point that many teams kind of start in the reverse order. We say, oh, let's make follow-up phone calls, let's do all these things, and we're just kind of throwing it out there to the wall and hoping something sticks. And we hope that you'll use these data reports to make a data-driven strategy where the things, the services that you're putting in place are really tied to the greatest opportunities for your organization. So how do you get all this? As I mentioned, these reports were originally created for participants in the Refuel project. We found so much value from them in the project that we did ask our Compass HIN data team to create these reports for every hospital in our network, and we are prepared to share those with you at this time. You're going to be receiving an encrypted email from the Compass HIN email address between April 26th and May 2nd. So that's over the course of this next week. You will see it is encrypted. You'll have to unlock it with your facility-specific information. The contents of this email will have, of course, this Compass HIN readmissions report and the associated data dictionary. It'll also have your facility-specific readmission report and associated data dictionary. Note that those data dictionaries are different. It is also time, biannually, we send out your HIN dashboards and your run charts. We send those out to the quality leads at each organization, allow you to review those and make any corrections that you may have to your data, or if you're a little behind, go ahead and get those caught up. And then next steps will be in mid-May, your CEOs will be receiving their HIN dashboards and run charts, and we will also include your facility-specific and HIN readmission report in the data dictionary, so your C-suite has the ability to review these reports as well. So next up, I just want to take a moment. Again, I do recognize we are past time, but would welcome any questions you have regarding the readmission reports or next steps in using them. If you have any questions, go ahead and just type into the chat. We'll give it just a few moments for those to come in. I don't see any questions coming in through the chat, so I just want to reiterate a couple points. Look for these data reports to come from the Compass HIN email address. They will come as an encrypted file in the coming weeks. Please do review them along with your HIN dashboards and run charts, and know that your CEOs will be receiving this email in the middle of May. We encourage you, if you have any questions regarding the reports or anything else in your HIN dashboard, to reach out to your improvement advisors, and we'd be happy to assist you. I have one question coming in on the chat I want to pause for. Will the slides in the presentation be posted for our review? Absolutely. So we have this presentation recorded today, and Sean will be posting the recording along with the slide deck to Hinnovation. Thanks for your question, Joanne. Very, very good. Thanks for joining us today. We look forward to seeing you next time. Have a great afternoon.